Beyond the LDL Hypothesis. I'm Carl Swedberg. I'm here at Cardiology Update in Davos, and this is EHJ Today. With me is Professor Ulrich Laufs from Homburg-Saar, and he has presented some interesting thoughts and discussions around the LDL hypothesis. Welcome, Ulrich. So tell me, what's the background to your presentation?
Well, Carl, thank you very much. Pleasure to be here. We had an exciting American Heart Association meeting in November with several interesting new studies presented. And in the main presentation of the IMPROVE-IT trial, a study that is testing adding ezetimibe to simvastatin for risk reduction, the presenter, Professor Chris Cannon, said that the LDL hypothesis would be supported by this data. And I would like to put forward the discussion whether we should actually still talk about an LDL hypothesis or whether we could actually say we are looking at an LDL causality. We have data from basic science showing that LDL is causal in plaque development. We have strong epidemiologic data running back to the Framingham Heart study that have been repeated by many other cohorts. And we have recent genetic data that show us that for each 1 millimole, which is approximately 40 milligram per deciliter, LDL reduction, lifelong, that's the important part, we have an approximately 54% risk reduction. And we have the statin trials. Chris Packard at the EHJ presented very, very interesting data from the West of Scotland study, a 20-year follow-up. The West of Scotland study, as you know, looked at middle-aged Scottish men, approximately 55 years old, with hypercholesterolemia that were treated with pravastatin at the time. And now using data linkage analyses, he was able, and his colleagues were able, to follow up for 20 years, and now we have real data on long-term statin effects. And it turns out that, first of all, statins are safe, and then it turns out that these middle-aged men had the continuous benefit. The curves continued to diverge to a total of 5 event-free life years gained. Scottish pharmacologist, hard endpoints, only looking at death and myocardial infarction, and tremendous effect. So number needed to treat for a 55-year-old, I think that's an important message, would be fairly high. However, when you translate this into other readouts, such as life years gained, event-free life years gained, it's a tremendous effect. Biggest effect was heart failure, by the way. So one of the most effective ways to prevent heart failure would be to treat a middle-aged man with a statin.
Yeah. But that was the statin aspect. Now, what did actually the IMPROVE-IT trial add to this?
Yeah, I think that's an important point. We had a series of neutral studies looking at different agents adding to a statin that did not meet the predefined endpoints. So the question really was of this study, when we start out with the patient that is treated with a statin to a low LDL, does further lowering add an additional benefit? And the second question was, does adding a non-statin intervention to a statin, is that also able to reduce cardiovascular events? So that was the question of the IMPROVE-IT study. They included 18,000 patients post-ACS.
But still, I mean, this was a huge trial, went on for a long time, so the important message was that a non-statin could improve outcomes with a focus on the LDL.
Yeah, I think that was one of the two scientific questions that were addressed by this, and of course the question whether ezetimibe would be a safe agent.
But still, I mean, the effect was modest, and will that translate into clinical practice, or is it more important that it can pave the way for further research into this topic?
Yeah, Important point. So we are looking at a baseline LDL in the control group, which was treated with a statin, of around 70. And the interventional group, including ezetimibe, was lowered to 54. So obviously, because LDL is so important for clinical events, the lower the baseline LDL, the lower is the absolute number of events that will occur. Now, the primary endpoint was met. And the question is, how do we translate it? I mean, have we ever treated a patient on statin with an LDL of 70 with ezetimibe? No, we have probably not done that yet. We have used ezetimibe for those patients that are not at goal or that cannot tolerate a sufficiently high dose of statin, for example, because of muscular symptoms or other reasons. And I thought it was really important and helpful that Chris Cannon, in his original presentation at the EHJ, included as one of his last slides the depiction of the IMPROVE-IT study on the CTT regression line. And what Professor Cannon said was that from his data, he concludes that the IMPROVE-IT data are on the CTT regression line, meaning that he sees the same extent of risk reduction per LDL lowering as was seen with statin. So that means, and that's the important point, that we can translate the results to higher baseline LDL levels. Now, the higher the baseline LDL is, the larger becomes the absolute risk reduction. And if you want to calculate the number needed to treat, I just made a comment about number needed to treat not always being the right parameter. But if you wanted to do that, the number needed to treat dramatically goes down as the baseline LDL goes up.
Yeah, but because from the IMPROVE-IT trial, I remember the number needed to treat is around 50 for then 5 years or something.
For the duration of the trial, that's right. That's the on-treatment analysis. Obviously, the intention to treat analysis is a little better, but that was the result, yes.
So what about the future then? I mean, there are now new agents coming for focusing on LDL reduction, but do they have other effects as well?
Right. Interesting times, and I think all people interested in lipid lowering, lipidologists, had a big smile on their face after the EHJ meeting for two reasons. Because we have seen a study that shows that the lower is better, and secondly, that a non-statin intervention was able to further reduce the risk. It also really reinforces the concept of LDL as the treatment target and to bring down our high-risk patients as low as possible.
So how much does this encourage the expectations that we are then seeing with these new lipid-lowering agents?
Well, we have the PCSK9 inhibitors. This is a drug that modifies the recycling of the LDL receptor. And it's a drug that is injected subcutaneously every second week or every fourth week, and is able, on top of statins and on top of statin plus ezetimibe, to further bring down LDL cholesterol by up to 40%. There are several of these drugs far down on the road of clinical development. Phase 3 studies are on the way, and some are recruiting very well. So we will see, and that's of course the important point, the LDL lowering and safety looking good. The important point will be, are hard endpoints reduced or not?
Yeah. What's your guess?
Yes, I think after the IMPROVE-IT trial, I'm very optimistic.
And we will have the first, when it's anticipated to end, I know about at least 2 very big trials. The first will report around...
Yeah, there's the Fourier trial and the Odyssey trial. Those are the 2 main ones, but there are other trials on the way. And from what I hear, 2018 for the outcome trials. But we have a lot of evidence accumulated already, and also evidence on clinical events, because so many, it's one of the largest trial programs run by several companies actually. So it makes sense to pool these data and there are follow-up programs. So we will have intermediate information that is not the hard endpoint, but that will be informative, especially for patients with familial hypercholesterolemia, where the LDL is really very high, where we have a large unmet need and a clear potential in that area.
Okay, thank you. So we will have more discussions to come here about this topic.
Well, thank you very much.
Okay.